Hello, and welcome to the Dental Learning Center. I'm your hostess, Dr. Marie Huggy. Today we will be discussing the design of the Kennedy Class II partial denture. Joining us in the studio today is Dr. Junior Poser. Welcome, Dr. Poser. Dr. Poser, do you teach partial dentures from a textbook?
Book? What book? No, Marie, for the last 18 years I've been making it up as I go along. A lot easier that way.
Well, Dr. Poser, our patient today is presenting with a Kennedy Class II arch form. Can you explain to our audience what that is?
Well, Marie, a Kennedy Class II arch form is a unilateral edentulous space posterior to the remaining teeth. This particular arch has no modification spaces, which are other spaces not associated with the space defining the classification. I'm assuming we will not replace number 32, so that tooth is not considered in the classification. Your viewers are welcome to review the Kennedy classification. It's also helpful to realize that this will be a tooth tissue supported partial denture, requiring a few modifications from the all-tooth supported partial denture.
You are so right, Dr. Poser. We all need a refresher now and then. What's next?
The patient has a few clinical findings which could impact our design. Of course, we have surveyed the arch in question.
Okay. What about having 11 mm from the free gingival margin to the elevated floor of the mouth?
This means that we can select a major connector without regards to vestibular depth. You know, we could select a linguoplate or a lingual bar. Assuming there are no other interferences to the path of insertion, such as tori or lingually tipped teeth, we probably would select the lingual bar because of its simplicity.
Why would we want a linguoplate?
We would use a linguoplate here if anterior tooth loss was a possibility. Normally the minimum thickness of the lingual bar is 2 mm. With 11 mm, some increase in thickness to increase rigidity is possible. Another factor to consider is what type of major connector is present on the patient's existing partial, if any.
I see. So in all likelihood, we are looking at a lingual bar. The next criteria we find is that the patient has no decay, existing restorations, or periodontal problems.
Right you are, Marie. Ideally, partial dentures should be fabricated only after treatment of caries and periodontal disease.
The maxillary arch is edentulous.
Yes, Marie. Let's assume the maxillary arch is free from complications such as combination syndrome or bony defects. We may take the liberty of reducing the occlusal load on the partial denture by limiting the number of artificial teeth on the edentulous side, such as not replacing the second and third molars.
Oh, capital, Dr. Poser.
The absence of bony protuberances and soft tissue undercuts allows us more latitude to select clasps. In this case, I note the patient is aesthetic conscious. We would like to select an infrabulge clasp in the anterior portion of their mouth, if possible. The
infrabulge clasp brings several advantages to the design, as well as improves aesthetics.
Right you are again, Marie. I personally like to use the modified T-clasp in the distal extension case.
Dr. Poser, this patient does not have any significant financial limitations. Should we recommend implants?
By all means, we should discuss various implant options with the patient. However, let us assume here that the patient has declined this plan and selects to have a conventional maxillary complete denture opposed by a Kennedy Class II mandibular partial denture.
You know, Dr. Poser, that when designing a partial we first have to establish a path of insertion and select teeth to be used as abutments. Can you give us an idea about these?
We have surveyed the cast with the occlusal plane parallel to the surveyor table. This is most convenient, is the easiest position to fabricate the partial denture, and the easiest to maintain. The tooth tissue supported partial denture derives its support from the edentulous ridge as well as the teeth. Rest seats are normally selected on teeth adjacent to the edentulous space. So, on the right side we select number 20.
Okay, what about the contralateral side?
On the dentulous side, it is best to extend the major connector and clasp as far posteriorly as is possible.
Why is that?
Marie, think of the major connector as a first-class lever. Lengthening the resistance arm makes the retention more effective, as demonstrated in the animation. Retention on the molar teeth not only will be aesthetically superior, but mechanically more efficient. Granted, access for tooth preparation is somewhat more difficult, and lengthening the major connector increases its flexibility.
I see, Dr. Poser. Which teeth and what sort of rest?
I would propose a double occlusal rest seat on 30 and 31 with an embrasure clasp.
Well, what about the guide planes?
Guide planes will be short, on number 20. Long guide planes will be prepared on the lingual surface of 30 and 31.
Again, Dr. Poser, we refer our audience to your brilliant video lecture for an excellent review on guide planes.
Bully Marie. Splendid.
Can we now locate our indirect retainer?
As usual, a keen observation, Marie. Once rest placement is established, we can locate the fulcrum line, and place our indirect retainer perpendicular and as far forward as is reasonably practical. The cuspid has no cingulum, but the first bicuspid will do nicely with an occlusal rest seat.
Bully? Dr. Poser. Dr. Poser, earlier I believe you referred to support from the edentulous ridge. Can you elaborate?
Marie, support from the edentulous ridge is provided by the retromolar pad and the buccal shelf. Both of these structures are more resistant to resorption than the residual alveolar ridge, which consists of cancellous bone. Both the pad and buccal shelf should be covered by the partial denture base.
Can you describe the snowshoe effect?
Yes, Marie. This simply means that to reduce stress per unit area on the ridge, the base should cover as much of the residual ridge as physiologically possible. Depending on a number of things, such as ridge anatomy and consistency, this basal seat must be recorded with border-molded custom impression tray.
Oh, do you mean that the arch requires 2 impressions?
Frequently, but not always, the corrected cast procedure must be employed to adequately record the tissue, both in its maximum extent and function.
Oh, Dr. Poser, that sounds painful.
Yes, Marie. Painful for the uninitiated, but with practice is quite simple and effective.
You said it was not always necessary, did you not?
Marie, it may be difficult, in some cases, to distinguish clinically any advantage to the procedure. My suggestion is to carefully place a framework with a trial record base, and examine carefully the base for tissue coverage, and whether or not anterior-posterior rocking of the partial occurs when one applies pressure to the base. This is where one exercises that ineffable quality of clinical judgment.
I think I can surmise that the base material for this would consist of a replaceable, reliable material such as polymethyl methacrylate.
Marie, your perspicacity never ceases to amaze.
Okay, Dr. Poser, how do you propose to retain the partial denture?
Marie, clasping requires a consideration of the anatomy, location of the undercut, and effect of the aesthetics. Here, we located the rest on the mesial of number 20. This has several advantages. One advantage is that it improves stress distribution on the ridge, as the base in function rotates with less arcing. Another advantage is that it allows the use of a cast clasp, which could be contraindicated with the distal rest. Another factor is location of the undercut. Although undercut may be prepared on the tooth, naturally occurring undercut is a personal preference. Let us assume a naturally occurring undercut on the distal of number 20. This could be accessed with an embrasure clasp or a modified T. In terms of aesthetics and conservation of tooth structure, I would select the modified T.
Quite so, Dr. Poser. With the modified T, upward rotation of the base causes the clasp to engage the undercut, thus providing a bit of indirect as well as direct retention. Now what about the embrasure clasp on 30 and 31?
It's really important to prepare the rest seat sufficiently. A common error is failure to open the rest seat to the buccal and lingual.
Okay, so we have a modified T on 20, with circumferential clasps on 30 and 31. What about reciprocal elements?
Definitely an area requiring attention. The reciprocation may take several forms. In this case, cast clasps would be used to reciprocate the retention on 30 and 31. These clasps should occupy the middle one-third of the tooth. In many cases, axial recontouring of the tooth is required to lower the height of contour of the abutment. Tooth number 20 will be reciprocated by a vertical bar minor connector located on the mesial and the distal proximal plate.
Alright Dr. Poser, I believe we already decided to use an acrylic base. Shall we retain it with a ladder?
Yes Marie. The ladder should cross over the arch and be designed so as not to hinder tooth setting. There should be 1.5 mm of space under the ladder for acrylic, and should be terminated by a tissue stop. Of course, the lingual bar major connector is used to connect the components. As you know, the major connector must be rigid. The bar may be thickened slightly to compensate for its length.
Okay, let's talk now about replacing the teeth. In the opposing arch we have a complete denture.
Marie, I like to reduce the load on the extension base when possible, and there are several things we can do. First, we can reduce the number of teeth replaced. Thus we need not replace 17 and 18. We can reduce the width of the occlusal table. And finally, we can increase occlusal efficiency by adding grooves and a more anatomic tooth form. Care is needed not to introduce occlusal interferences.
Well Dr. Poser, you have in your playlist video lectures which provide more detail on all these topics. It's been a pleasure to... Oh wait, I'm told we have a caller on the line who wants to ask a question. Hello, and welcome. Please give us your name and question.
Yes, this is Dr. Buster Bedcheck, and I wanted to know if you use a textbook. You know, I use my new book, Picture Perfect Prosthodontics. Written by Buster Bedcheck in collaboration with Stickfigure and Goon. We tell patients how to take a picture of their mouth, send it in, and get a same-day partial denture. Stickfigure also tells them how life can be perfect, and Goon endlessly repeats the phrase excellence in dentistry.
Hello, this is Bill at the local rehab center. I apologize for Dr. Bedcheck's interruption. He's not supposed to have a phone in his